Do you know muscle catch is not a thing? I mean, the term muscle catch is not an authentic approved medical diagnosis. But oftentimes our patients use this term very easily to us, saying that I got a severe catch in my neck, I was lifting some weight and I got a sudden catch in my lower back. So the term catch is very commonly used by the public, yet the term muscle catch is not a precise medical term. Our patients use this term catch to explain the characteristics or the nature of the problem that they have. Usually it will be acute in nature, I mean sudden onset. The area of the catch do differ. Most patients will feel the catch is happening in the upper trapezius area. Sometimes the catch happen in the sternocleidomastoid area. Sometimes the catch will happen in this area. We call that as mid-thoracic area. And the lower back catch, we know that it will be happening in the paraspinal region in the lower lumbar spine. So these are the locality where the common catches do happen. I'm using the term catch because most of you understand, but I was pondering what that term catch really means physiologically or even neuropathophysically. How a muscle can catch by itself? A muscle cannot contract by itself. For every contraction, a muscle needs a nerve impulses. So muscle can undergo contraction, muscle can undergo relaxation, muscle can get affected by spasticity or flaccidity or even rigidity. We all know the neurological underpinning of flaccidity, spasticity and rigidity. There are some occasions when you can also see fasciculations and myoclonus. These are all the signs of either upper motor or lower motor types of lesion. So most of these phenomena happening in the muscle like spasticity, flaccidity, rigidity, myoclonus, fasciculations, these are all mostly a neurological condition. So here the muscle is not at fault. It is just expressing a symptom of an underlying neurological problem. No muscle can contract without the order coming through the nerve to the muscle. When the orders are not coming to the muscle is just dead. It cannot contract. We all know that. There is one more strange phenomena called as cramp. This cramp is to do with metabolic, electrolytic, water imbalance related or sometimes hormone related. In some case of neuritis, the muscle can undergo cramps. There are so many reasons for local muscular cramp. Calf muscle is the commonest muscle where people get cramp. The pathophysiology of cramp is something entirely different. You literally see the muscle contracting, shortening. You are unable to plant your foot on the ground due to the cramping of the calf muscles. That is transient in nature. It won't last for longer, maybe about 1 minute, 2 minutes. It will be settled by itself. So this is called as cramp. Don't confuse cramp with muscle catch. Now coming back to the term muscle catch, as I mentioned, catch is a feel of the muscle is feeling very tight. If someone has a catch in the upper trapezius, these patients cannot move an inch. You try to move, they get severe pain. They are happy without moving than you moving. So any sort of movement you try to do, the pain will get worse. So these patients are the one who wanted painkillers or muscle relaxants so that the pain can come down. What could be the neuropathophysiciology of the catch? The muscle's activity is decided by the nerve. When the nerve supplying the muscle is hyper irritated, it will bombard the muscles with messages and the muscle will feel like hypertonic. Such irritation at the nerve level will make the muscles to get more or less like a neurogenic protective spasm like sensation that it will not allow the patient to do any movement. You know, a nerve has both sensory and motor fibers. When the motor fibers are irritated, it will give the tonic impulses to the muscle and muscles feel very tight and hard. Whereas when the sensory fibers of the same nerve affected at the root level, usually at the spinal column. For example, if someone gets a severe catch in the upper trapezius, usually at C3, C4 level, the nerve will get compressed, and that nerve, when the sensory fibers are affected, the messages go up to the brain and feels pain in the upper trapezius. And when the motor fibers are affected, it gives the tonic impulses to the muscle that makes the muscle very tight and feels very hard. So it's a combination of both pain, movement restriction, pain on touch, we call that as a palpatory pain, and sometimes accompanying with autonomic disturbances like dizziness and vomiting or nausea and so on. Muscle spasm is the closest terminology to the muscle catch. So usually when the nerve is irritated, as in case of cervical and lumbar disc pathology, there will be an abrupt mechanical or inflammatory compromise happening at the nerve which is supplying the muscle. In that way, the nerve will make the muscles to get that catchy feeling or a spasm. A decade back, we truly believed that such spasms are local in origin, and then we ended up stretching the muscle, but only to know that the more you do the stretching, the bad the pain becomes. Some patients do tell me that, doctor, in a year about 2 or 3 times I get such kind of catch. It used to go away by itself. Maybe 1 or 2 days I take rest. Sometimes I take tablet, but it used to completely go away. But this time when I got the pain traveling all the way to the arm. So what started as a muscle catch has now become a persistent radicular pain. So this is the hierarchy of the pain progression over a period of time. So it all starts as a muscle catch. Later on, it will become a well-established discogenic pain, discogenic related referred pain, discogenic related radicular pain. Once you get a catch in your life, you tend to get the catch again. Since you don't know why the catch is occurring, you can't avoid next episode. Maybe you may get after 6 months or even after 1 year, but you will anyway get it as time passes. So what this catch essentially mean? The catch is a sensation felt in the muscle due to the nerve irritation happening at the spine level. Usually the mechanical inflammatory mediated nerve compromise happening at the spine level, making the sensory and the motor neurons getting affected. Motor neurons will bombard the messages to the muscle. Sensory neurons will carry the message up to the brain, causing the pain. So this causes severe pain, movement restriction, pain on palpation, and autonomic disturbances. You know what? Morning when they wake up, they can't get up from the bed that easily. They take 10 minutes to 15 minutes to turn to one side and slowly they get up from the bed. So the catch can cause such severe functional restriction. Most of the patients will say that, doctor, morning I'm struggling to get up from the bed. So that is one of the manifestation of the catch. Even though I'm using the term catch now, the real medical terminology that I would prefer to use is neurogenic mediated muscular spasm due to inflammatory mediated discogenic referral pain or discogenic radicular related pain. To make it simple, the actual pathology is happening in the cervical spine, either at C3, C4 level or C4, C5 or C5, C6. In the lower back, it's usually L4, L5 or L5, S1. Once you get the spasm, it's very difficult to deal with physiotherapy. All you can do is pain management. You can put them into hot pack or cold pack or give some modality, make them comfortable, but the pathology has to solve by itself. You don't try to stretch any muscle there. You don't try to manipulate anything there. If you manipulate or mobilize, you know the consequence of it. I'm sure most of the seasoned physios would appreciate that. For some people, the exercise will work, but most of the people, time is a solution. But make sure that you address the pathology correctly so that next time they don't get the spasm. It's because these occasional spasms are the one which are going to become an established pain conditions, and later on it's going to become a typical radicular pain at the upper extremity or at the lower extremity. I hope I made some sense to you.